Hi, and welcome to Acadicus. This is Nick Slayman. I'm a pediatric intensivist at the DuPont Hospital for Children, and welcome again to our COVID-19 Command Center here at Acadicus. It's set up to have various areas that can give information all in one place, so you can learn, you can teach, you can record videos, and you can kind of keep up with the flood, the avalanche of information that comes in hourly, daily with COVID-19 as this pandemic crosses the globe. So what I'd like to talk about today is the coronavirus COVID-19 global cases by the Center for Systems Science and Engineering at Johns Hopkins. So anyone who has Googled the Johns Hopkins tracker is able to get on this free website that gives you up-to-date information, updated every few hours on what's going on with the COVID-19 infection. And you can see that we pulled a snapshot in of this graphic, which was done on 3/25/2020 at 12:04 p.m. and 51 seconds. Things have gotten worse, unfortunately, since then. But I think what it's important to point out is that they'll give you a total number of cases in the upper left. We're now over 600,000 total cases worldwide. And then it'll break you down by sovereignty. So for a long time, China, with the Wuhan market being the presumed epicenter of this, with some transmission, zoonotic transmission from bats to humans is what the current theory is. China was the epicenter, and China was the leader in terms of number of cases. China in the past several days has surpassed, so Italy continues to rise, and Italy is in the 80s, 80,000 cases, and the United States has jumped from the 25th to today, which is Sunday the 29th. So in 4 days, the United States is up over 126,000 cases. The other thing that's important on this graphic, I think, is total recovered patients and total patients that have expired. So the mortality is very controversial. Everybody gets very wrapped up in the total number of deaths divided by the total confirmed cases gives you a mortality rate. And in Italy, for example, that has an elderly population where smoking is very common, you can see that they've had a large number of deaths. Their death percentage, when you divide total deaths in Italy by their total number of cases, is about 10%. The United States, as of yesterday and today, was about 1.5%. Spain and the rest of the world, if you put 19,784 over 441, 187, is about 4.2%. So the problem with these numbers is that testing kits are restricted and limited. So we think that the total number of confirmed cases is much larger, maybe 1 million, maybe 3 million people are infected. And the total number of deaths, we know that, that's a concrete number. It's something that has to be updated greatly, but if the numerator stays relatively the same and the denominator keeps getting bigger, the mortality number is probably not 10% in Italy. It's probably not 4.2% worldwide, and in the United States it may be under 1. So this isn't just a bit of kind of glass half full kind of optimism, but it does reflect on the fact that we can't test enough. We don't have enough test kits. We don't have enough testing centers to really know what our total number of confirmed cases are. And as we referred to in another video, this idea of having super spreaders who are completely asymptomatic and would never think to go get tested, because why would I get tested? I'm not feeling sick at all. That's a problem as well. So we don't really know what this number is. So we have no idea what the mortality of this virus is. What we do know, though, is with the total number of cases, I'm guessing in the next 2 to 3 days we'll approach 1 million people. This virus is extremely contagious. There has been talk about, is this a droplet virus that only spreads 6 feet, or does this have airborne properties where it can float in the air and you can kind of walk through a cloud of that? There's been a lot of controversy about, should everybody just walking around be wearing a mask, or only the. So I think the bottom line on that is that we don't know the total number of cases. What we do know is that this virus is aggressive, this virus is highly contagious, and while we thought it would mainly affect elderly and immunocompromised, it does not seem to spare and decide along race, creed, religion, or age. This virus affects everyone, and the scary part of it is you could be an otherwise young, healthy, athletic, in good shape with no comorbidity patient and end up very sick and on a respirator, or even perish from this virus. So again, it takes back this concept of flattening the curve. washing your hands, covering your cough, covering your sneeze, self-isolating when you have symptoms for 14 days, staying away from other people, listening to your local government's advice on closures of restaurants, bars, gyms. Self-isolating and staying inside is really the key to slowing the spread of this. With the numbers on this map, obviously, we haven't gotten this under control in any way. But if we can flatten that curve and not overwhelm the health system at any one time with a large influx of sick people, and we can spread out the number of infections over weeks to months, we can perhaps serve each person with medication, mechanical ventilation, supportive care, and help them recover before the next wave of people come in sick. Again, the COVID-19 Command Center here in Acadicus is open and ready for business. You can come in and look at the graphics. You can bring a group in here and teach, and you can record your own videos. Thanks for joining me. Have a great day. Hello and welcome to Acadicus. I'm Dr. Nick Slayman, a pediatric intensivist at the DuPont Hospital for Children. And here at Acadicus, we've set up what we call our Coronavirus COVID-19 Command Center. It has various different pieces of information, data that we're trying to put all in one place so that it's a resource for people to try to keep up to date with the latest information that comes out. Every few hours to every few days, information changes, and as this epidemic outbreak continues to spread across the United States, we'll be here to try to be a teaching resource for you and your residents and fellows, medical students, nurses, and respiratory therapists. So I think the first place to start is differentiating between the coronavirus infection, the flu, a common cold, or seasonal allergies as we're in the spring, and in the Northeast in particular, in the middle part of the country as well. Lots of trees are starting to shed pollen, and some of the symptoms can be confusing to try to figure out what do you have. So the first differentiator on our chart here is, do you have a fever? And if you have a fever, that puts you into the right side of left side of the chart, where you could have coronavirus, influenza, or the common cold. Fever is common with each of those. People who suffer from allergies usually do not have fever with their other symptoms. So the next branch point is, do you experience any shortness of breath? If the answer is yes, coronavirus has been very notorious for making people very, very short of breath, having a very, very strong cough that is non-productive of mucus. It's very dry, and giving them kind of that sensation that when they walk or when they go up the steps, they get very dyspneic, they get short of breath. If the answer is no, and you don't have any shortness of breath, you could have the flu. Although I think anyone who's taken care of a patient with influenza, or if you've ever had influenza, certainly coronavirus and influenza share a lot of these symptoms. They both have cough, they both have fatigue, they both have weakness, they both have exhaustion, they both have fever. So even though this infographic tries to simplify this, it is very, very difficult to tell the difference between influenza and coronavirus. What is a good source of information, however, is that a company called BioFire has a 15-target PCR. So they take small fragments of DNA of a virus and then amplify it so that you can measure it, and they can tell you what you have. While coronavirus COVID-19 is not yet on that panel, you can get rapid flu testing to rule you in or out for influenza. Now, another thing that makes this even more confusing is it possible to have both things at the same time? Unfortunately, it is possible, and there's been some literature recently describing co-infection. So people having coronavirus and rhinovirus, the common cold, or coronavirus and influenza. So just because you test positive for influenza does not necessarily mean you don't have the coronavirus, but Occam's razor usually does govern in medicine that the simplest explanation is the most common. You have one thing, not two things. You have one thing, not four different diseases. So if we go back to the right side of this infographic, so do you have itchy eyes, yes or no? If that's a yes, you may have allergies, sneezing, rhinorrhea, or runny nose. Those are all common with allergies, but also we've gotten some information in the past several weeks that patients with coronavirus have conjunctivitis. So they have irritation of the red inner lining of the eyelids, becomes very pronounced in the outbreak in Seattle. Many of the nurses noticed that their patients had red, irritated looking, sometimes itchy eyes. So again, makes this infographic very difficult to use. Do we have a clear cut, you have this versus that? No, we don't. Common cold, sneezing, again, runny nose, rhinorrhea. You can have some chest discomfort. So I think the bottom line is we're at a point in this country where it is very difficult to tell who has coronavirus and who does not. You've heard probably on TV about the super spreaders. They have no symptoms at all. Some of the NBA athletes said they feel great. No fever, no cough, no shortness of breath, no chest discomfort, no nothing. But then again, they tested positive and could pass that virus on to other people. So I think it brings us to our next set of slides, which we're going to step onto over here, which talks about how do we spread the coronavirus. So in the upper left-hand corner, you can see our incubation timeline. So at time 0, you're infected, and days 1, 2, and 3, notice that you are virally shedding. You are able to spread that infection to other people. But notice that your symptoms don't appear till day 5. So from day 0, when you get the virus, all the way through day 5, you are shedding virus, but you may have no symptoms at that point. Now, this is a generalization. Everybody's different. Some people start their symptoms on day 1 or 2, but in general, most people start having symptoms on day 5. So it's very, very difficult to control the spread of the virus when you don't know that you have it. And then if you look at the rest of our kind of quarantine period, so if you test positive, people say that you should self-isolate, stay away from everybody for 14 days. So you can continue to infect other people for that full 14 days. And again, for those first 5 days or so before symptoms appear, at day 3, you're starting to shed virus. So it's really important to wash your hands, to cover your cough, to cover your sneeze, and to stay away from other people and take this self-quarantine seriously. The pictures of people going to concerts and people going to spring break and people going to the beach and people kind of flouting this idea of social distancing and staying away from others really comes to the fore when you look at this timeline, that I'm infected at time 0, but I'm shedding virus somewhere between day 3 all the way through day 14, and I haven't had any symptoms till day 5. So I feel fine. I don't know that I'm sick, or maybe I'm a super spreader and I never feel like I'm getting sick. That's a big problem. So this next set of graphics takes you through how does this affect people. So you see a guy in the upper left-hand corner having a cough and a sneeze, and he has now aerosolized that virus in droplet form. So the droplets can travel up to 6 feet. They can survive on surfaces. You've heard about plastic and metal and cardboard with the virus surviving different time periods, sometimes up to hours on different surfaces. But second guy comes along and inhales some of those particles, or he wipes his hand on a table where those particles have finally settled, and then he rubs his eyes, he rubs his nose, he rubs his mouth, he touches his face, and the virus now enters his body through the mouth, nose, and eyes. So that's another part of our PPE guidance that we'll give in another tutorial. It's not enough to have your mouth and nose covered. You're going to have to cover your eyes with goggles to allow the particles to not enter through the mucous membranes there. So in our next graphic at the top, you start to have symptoms. The virus moves into the back of your nasopharynx. Some people describe sore throat as a common coronavirus symptom, and then it begins to move downward into the airway. So we have a diagram here of the trachea, the right and left mainstem bronchi, multiple bronchial divisions into the lungs, right, upper, middle, and lower lobe, and left lung. And we have a breathing lung here in the COVID-19 center that we'll use in other videos. But once it's down into the lungs, that's where it causes acute respiratory distress syndrome, or ARDS. It also sets the lung up for a secondary bacterial infection, which can be fatal. So your immune system is so busy fighting the virus that then a bacteria like pneumococcus, strep, or staph decides to jump in on the party and make you that much sicker. And then over here in this final graphic, you can see that that patient has now had respiratory failure, is in an intensive care unit, and is attached to a ventilator. So does this happen for everyone? No. But the early advice that this was going to hit the elderly and the immunocompromised, like patients on chemotherapy, primarily that's true. But we have plenty of cases at this point where patients who are much younger, teens, 20s, 30s, 40s, 50s, and 60s, otherwise healthy people who are non-smokers, have no other comorbidities, exercise, eat right, they're getting this sick. They're getting put on mechanical ventilation. In some cases, they're getting put on ECMO or extracorporeal membrane support. With New York as our epicenter right now, as of Sunday, March 27th, ventilators are running in short supply, as well as personal protective equipment like masks, gowns, gloves, N95 respirators. There is a push, and we'll add some of these diagrams to our COVID-19 center about splitting ventilators and having the tubing run to 2, 3, and 4 patients. Makes it much more complex. But with a shortage of ventilators, the number of total mechanical ventilators in the United States versus the predicted number of people who will need mechanical ventilation, we will never, ever. I'd like to talk about this flattening the curve. Anyone who's turned on the news or radio in the past 2 weeks has heard about this. This isn't about preventing transmission anymore, because I think the horse is out of the barn and we're not going to stop the spread of this. We're up to over 600,000 cases in the United States at this point. 600,000 cases in the world, with over 126,000 cases in the United States. The idea of flattening the curve, however, is if you have everyone sick all at once, which is this red peak, you overwhelm the healthcare system's capacity. There's no ventilators, there's no PPE, doctors and nurses are sick and they can't take care of the hundreds to thousands to hundreds of thousands of patients that are all sick at the same time. Flattening the curve says that if we look along this x-axis where time is, if we let people get sick over a longer period of time, so we have mini surges and we stay below that dotted line, we're able to keep up with the healthcare system's capacity. We can get some people better and off ventilators in time for the next person to have their turn on the ventilator. We have enough time to clean and turn over rooms. We have enough time to get new equipment, new masks, new N95 respirators, new gowns, new gloves, so that we spread this out over April, May, and unfortunately even June. So that's our first quick introduction to the COVID-19 Command Center. I hope you'll be able to join us in here. And again, with Acadicus, know that you can make your own videos. Hi, my name's Nick Slayman, and I'm an intensivist at the DuPont Hospital for Children in Wilmington, Delaware. And in this next COVID-19 Command Center video, I'd like to go over PPE and some of the ideas between how to put it on properly, how to take it off properly so you don't self-contaminate, and these concepts of reusing, which are starting to come out now. So at the top of our CDC graphic here on the left, how do you put on your PPE properly? So first, this graphic doesn't talk about it, but you should wash your hands. So before you touch anything, you should go ahead and wash your hands first, because presumably you're going to be touching a patient. And then you take your yellow gown, put your arms in the sleeves, make sure it covers neck all the way down to knees. These gowns tie up in the back. So you put your arms through the sleeves, you fasten at the neck, and they also have a tie at the waist. You can fasten at the waist. So you should fasten both, because you don't want it to kind of drift forward as you lean forward and examine your patient. Step 2 is your mask or respirator. Now it's becoming more and more controversial. Before it was simple masks are not useful. Simple masks let virus in from the sides. They don't have a tight seal, don't use them. In the past couple of days, there's been some ideas about if you're working in a hospital at all, you should be wearing a mask all the time, despite the fact that our simple surgical masks here on the left are starting to run out. But the bottom line from my standpoint as a critical care doctor is, if I am going to be taking care of a COVID patient and potentially intubating the trachea of a COVID patient where they could be aerosolizing virus in my face, I need what's on the right-hand side, not a simple mask, but an N95 respirator or higher. So these masks are usually made by 3M. N95 means that in a test where you try to measure the amount of particles that can come through the mask, 5% or less will get through the mask, 95% will be weeded out. The size, the pores in the mask are sufficient to keep COVID-19 and other things like tuberculosis out. What's important, though, is that you have to have a good fit. So if you are a man and you have facial hair, you have to be clean shaven. You have to use the bridge piece along the nose and mold it so that it covers your nose and seals. And then around your cheeks and mouth, there can be no spaces in between. It shouldn't be that it's difficult to breathe through, but it should be that you cannot smell or taste anything that's coming in from the outside. And N95 fit testing often has a salt solution with a detector inside the mask to see if any of the salt water is getting in. So you really want to mold that nasal piece. You want to mold it around your cheeks, and then you want to make sure it's fit snugly, and you pull the bands. There's two of them up and over your head. One is around the back of your neck. One goes over the crown of your head. So anyone who's intubating a patient should be using an N95 or higher. Now, some people are starting to talk about using half face masks, also by 3M, that have dual respirators on either side, seen in auto body industry, painting industry, can filter out organics, can filter out biologics. The rating on those that you want to look for is a P100. So the P100 respirators have filtration of 99.97%. So 0.03% or less can get through those. So does that mean to say that an N95 is not good enough? No, I think we have good data that says an N95 is excellent for preventing COVID infections in nurses, doctors, anesthesiologists, respiratory therapists, but we're afraid that we may be running out of N95s. The other concept is, should we be reusing N95s? So normally you use them once and you throw them away. Now, when we talk about how to take off this equipment properly, we'll be talking about, do we need to keep these? So that brings us to step 3. Because COVID can enter the mucous membranes of the nose, mouth, or eyes, you need goggle protection or a face shield. Either one of them are fine. They're wipeable. The advantage of a face shield, though, is that if the entire face is shielded, the outside surface of your N95 mask isn't getting any viral particles on it, and you can reuse it more readily. And then we want gloves. Some people are suggesting double gloves, although that hasn't been supported with evidence, but some people are wearing an inner glove and an outer glove. Now let's step over here next for how do we take this stuff off without contaminating ourselves. So I like this graphic because it shows that you can slide your finger under the rim of your glove and turn it inside out. Presumably all the COVID is on the outside of the glove. We don't want to touch any of that. So we want to turn the gloves inside out, drop them in the trash. We want to bring our goggle strap or face shield strap from the back over the front, and we want to wipe down that face shield with a Clorox wipe. Okay, we need sodium hypochlorite or higher to decontaminate the face shield so we can use it again. 2 weeks ago, we wouldn't have been talking about any of this. We wouldn't be talking about saving face shields or saving N95s. We'd be saying throw it away. The reality is we're running low and we're starting to recycle. So your face shield should come off from back to front and then be wiped with a new set of gloves. You never want to wipe with your bare hands. Your gown is probably the easiest, so you can untie the back neck strap and the waist strap and then turn your gown inside out, pulling your hands backwards through the sleeves so the sleeves invert, and then you throw that in the trash. You can wash in between each one of these things or hand gel in between each one of these steps, and I personally would take off the gown, then I would wash my hands again, and then I would work on my respirator. So again, we want to take that straps back to front. We don't want to put our hand on the front of the N95 respirator if it's got any chance of having been contaminated with a viral particle, because now our hands are contaminated. But again, if we wear that face shield, we're hoping that we can use N95s over and over again, shift after shift, weeks at a time. But what they're recommending is taking off from back to front, having that bag, having that respirator dropped into a paper bag where you can use it again. Now, Duke University has come up with a way using hydrogen peroxide that's aerosolized to re-sterilize the N95s. Not every place has that capability, but that's starting to be talked about. Can we use this, something more sophisticated than a paper bag and a face shield method? Can we re-sterilize these N95s without damaging them? And then step 5, again, washing your hands, sometimes in between steps, I would recommend especially between gown and N95 because you're pulling your arms through the sleeves. Presuming that we have enough hand gel to do that over time. So again, some steps to help keep people safe who are working in the hospital, with special consideration on people who are intubating COVID-19 positive patients, opening their mouth, bag mask ventilating them, bag ET tube ventilating them, is aerosolizing COVID-19 throughout the whole room. You have to protect yourself with an N95 or higher, gown, gloves, goggles, and face shield. Thanks again for joining me.